Yeah. I you can hear me okay, I take
Yeah,
it?
all good.
I appreciate this is obviously being recorded and subsequently shared, so I might not be as controversial as I'd like to be, but
I think
No,
you should at
please,
this stage in your
please.
career. At this stage in your career, Chris.
I'm not that old, Mark. So, I mean, great to hear Richard's stuff, and you know, just a reflection on just how difficult it was to link that data. And I will not attribute the quotes, but I might come to some things I heard during the discussion, which were quite scary, really. So I'm going to talk about data in healthcare. I'm a renal physician practicing and also an academic at the University of Kent in the Centre for Health Services Studies. I'm really going to talk about, I was going to try not to talk about COVID too much because we've all had too much of it, but actually I think it changes so much that we're going to have to discuss that as, I think, a huge opportunity in terms of data sharing in the future. So I'm going to talk about a few of the barriers, a bit about predictive modeling in healthcare and some of the work that we've done. Wearables, Internet of Things, some work that we did with the all-party parliamentary group on AI, and I know James Hadlow, who presented to them, is in the audience today, and then talk about the open data pledges without preempting Mark's discussion too much. So barriers, we are beset by regulatory reporting and the requirement for operational dashboards. One of my pet hates is the RAG chart, which is regularly in use across the NHS, and I was not surprised to see one in the presentations on Saturday night. So a lot of our operational work is quite turgid and it interferes with our ability to innovate in terms of data presentation. Expertise. This, I think, may well change in health, and Mark and I have seen this already, that a number of people are reflecting following the COVID, well, the first COVID pandemic, and I may be thinking that working as a quant in a bank in the city isn't necessarily as fulfilling as it might be, and are really looking to healthcare and other places to work. And we've certainly seen that in people coming forward, thinking about working with us. So that's a great positive, and hopefully that will continue. But at the moment, we're well aware that health doesn't pay as much as other areas in terms of data analytics, and it's often very difficult to recruit. This is a huge barrier, and I'll move on to a more detailed rant maybe about this in a minute. But security and regulatory bodies regarding the secondary use of data are very difficult to navigate, and as Richard alluded to, it's not necessarily because of the wording of the legislation. It's discussion and argument about the interpretation of such legislation. And yes, we were in discussions about whether this was medical or scientific research, and also, interestingly, and the impact of COVID on this, which I'll come to in a minute, has been during the discussions, I heard arguments saying that data privacy in certain circumstances trumps preventing, in this sense, severe intimate personal partner violence or murder. Now that seems to me to be completely preposterous as an idea, but these arguments are put forward, and I think we've come a very, very long way since March of this year in what we are prepared to do or allow in terms of data usage. And I think it's an opportunity for us to really demonstrate the benefit of that. On the counter argument, I think when I'm trying to work out how we are going to link health and other data, it's not about the legislation, it's about passing the Daily Mail test that, you know, are they going to see this as something they can put on the front page? And I think the absolute key to this is, and this is part of Mark's discussion later, is public and patient involvement and engagement. It's being open, it's having open websites, it's publishing what you've used data for, what the results of that use of data are, and it's obviously allowing people clear and straightforward routes to opting out if they wish to do so. And I think you know, lots of efforts have been made nationally and regionally around this. It is very difficult, very time consuming, but it is absolutely key if we are going to win the public trust in terms of use of data. And the final thing, which is obviously in linking data, is the database structure. And we've had many discussions around problematic areas linking either health and other social care data, or even health data between organizations. And I'm not going to go into great detail about that, but I'm sure this is a learned audience and we're all fully cognizant of the massive problems in terms of codified and non-codified data in healthcare. Kent, we have some great opportunities. My hexagonal drawing is sort of designed to look a little bit like the peninsula. That is one of our advantages. We have a very complete data set. So we are we are surrounded by sea. We have pretty much one laboratory service centered across 3 acute hospital trusts. And we have increasingly very good relationships between primary care, secondary care, social care, community care, and other agencies such as the police, as we've discussed. We have an academic element, and we are aiming for this data to feed into a research consortium covering Kent, Surrey, Sussex. Because of the demographic of Kent, the longitudinal nature of this data is very good as well. So what have we been doing in the last 10 years BC, that being before COVID? A lot of work on predictive analytics, looking at individual factors, social factors, adherence factors, but also Mark and I have been exploring how we might apply predictive analytics in terms of organizational structure, so that we actually plan our health services based upon facts rather than political or other arguments. And so modeling how we deliver services to best serve our population. So some of the predictive analytics we've looked at have been around, you know, can we predict people who might not come to outpatients? That might be because they've been to outpatients 3 times in the last week. It might be other characteristics or whatever. And how can we engage people who don't necessarily engage with healthcare as best they should? We've done a lot of, or I've done a lot of work in risk modeling in health, including predicting acute kidney injury, falls and death in the elderly, from analysing primary care data, particularly prescription data, the deteriorating patient in hospital. So we've done work with the Nuffield Trust and linking observation data across multiple organisations to see if we can understand the deteriorating patient. I put the problem with a lot of predictive modelling has been that we tend to state the bleeding obvious and warn clinicians about something that they already know. For example, elderly, frail individuals who are very sick tend to do badly. And it's how we pick a needle out of the haystack and pinpoint individuals where intervention will alter outcome. And a good example of that is primary care attendances prior to being admitted as an emergency with bowel perforation. So there's an excellent publication demonstrating that if you normalize attendances, you can see them increase in the months prior to what is a very serious adverse event.
Chris, 2 minutes, if that's all right.
Nearly there. So
thank you.
So I'll pass this slide. I put this slide in because I got it out of a slide set from 2016, which I thought was quite interesting. And yes, if we've been better at linking data, would we have been better at predicting what was happening? Probably, actually. You know, that is a real shame. The other thing about the epidemic prediction is about 4 years ago, we put in a proposal asking people to opt in for research. And this was to a large funding body. It was turned down on the basis that the view was that people just wouldn't. That's been, it's abundantly clear that that isn't the case. That's been implemented in terms of COVID-19 testing, and opting in has been very high. Wearables. So we did a lot of work in terms of public and patient involvement and engagement, particularly relating to people living with dementia. And James Hadlow on the call presented that data to the APPG last year. And I think what we did there was we took a group that was going to be very, very difficult, a bit like Richard's data linkage. We knew it was going to be a challenge, and use that as a use case for how we might overcome barriers. Obviously, my aim would, in a closed healthcare system like Kent, would be to develop smart healthcare, you know, using all sorts of data flows, linking them all, and allowing much better health planning and much better prospective intervention in the primary care setting, as well as secondary care. So Mark's, I've nicked these from Mark, but give the data back, save lives, not data, radically open and share my data. So just a couple of reflections following COVID. There was a good publication by Tim Gardner in June from the Health Foundation, looking at people's attitudes to how healthcare is delivered. And they have changed dramatically since the COVID-19 pandemic. There have been 12 million downloads and counting of the COVID-19 app, and we can all, I don't want to get into a long discussion about how that's being run, but I think it shows an appetite for people to be involved. I, of course, found an article in the Daily Telegraph suggesting that they wouldn't be downloading the app. I didn't read the entire thing because I'm not prepared to subscribe to it. and I think the final thing to say is that there's been a lot of increased use of secondary use of data in the COVID pandemic. And I think we need to push very hard to for people who sit on panels trying to prevent the secondary use of healthcare data, to demonstrate where the harm has been in opening up data in the setting of COVID-19. Because I can tell you, we've got many, many, many examples of significant good. An example, Ben Goldacre's paper of 17 million individuals, which guides my practice daily in terms of giving people advice about their risk of death as a result of COVID-19. So that's my thought. Thanks very much.
It's